Greetings and welcome to Improving Child Survival at the Intersection of Nutrition and Birth Defects, a webinar hosted by Nutrition International's Folate Task Team, which is focused on laying the groundwork and implementing a global strategy for the control of folate deficiency and the prevention of related neural tube defects. You'll hear more about the Folate Task Team later in today's program. I am Aliki Pappas-Weekland, Project Consultant for the Folate Task Team. I will serve as moderator for today's webinar, together with Ms. Jessica Poulin, the team's Knowledge Translation Officer. I'd like to just have a side note here to say that we're very excited to be with you today, especially as yesterday marked the 2018 International Day of Persons with Disabilities. The theme for this year's International Day of Persons with Disabilities is empowering persons with disabilities and ensuring inclusiveness and equality. We have an exciting program planned for today, and one that I know has broad stakeholder appeal. In recent years, many countries have seen reductions in under-5 mortality from infectious diseases. One of the results has been the realization for greater focus on the prevention of other causes of child mortality in order to achieve further improvements in child survival. Birth defects, including neural tube defects, as causes of child mortality have greater significance, and they must be considered in country strategies for reaching the health outcomes that are targeted in the Sustainable Development Goals year 2030. Today's webinar is designed to provide information and to stimulate discussion from two vantage points. The first is science. We want to understand science. We want to know more about what neural tube defects are, their global burden, and the role that nutrition is playing in prevention and risk reduction. The second point of view is the importance of striving for a better life for everyone, and what that looks like specifically in Ireland, Uganda, and Argentina. Our goal today is not just to provide facts, but we want to help expand perspectives, to share a more holistic view of the many facets to NTD risk reduction, and hopefully to stimulate ideas and connections. Before we do get started with our wonderful list of speakers, I'd like to go over just a few logistics. All of your lines have been muted, but your chat function is enabled. You are able to send a chat message to the host. Throughout the presentations, we'd ask that you please send any questions or discussion points that you'd like to raise to the host via the chat function. Time permitting, we plan to address 1 to 2 questions following each presentation. And then we've planned for ample time at the end of the program for more questions and discussion across the full range of topics. All of our speakers will be available for that end of webinar discussion period. So, without further delay, let's go ahead and get started. Over to you, Jessica.
Thank you, Aliki. Our first speaker is Ms. Amy Cordero. Amy has been with the U.S. Centers for Disease Control and Prevention since 2009. Ms. Cordero is a public health analyst and deputy lead for the Prevention Research Team in the Division of Developmental and Congenital Disorders at the CDC, where she provides strategic direction and guidance for CDC's Birth Defects Count initiative, a global initiative to significantly reduce death and lifelong disability resulting from neural tube defects. She is the lead for the initiative's Southeast Asia activities, working closely with global and regional partners to advance and evaluate birth defect surveillance and prevention efforts in the region, and has extensive experience conducting systematic reviews and analyses in support of the development of national and global policies. Amy, over to you.
Hello and good day, everyone. Thank you so much for that introduction, and thank you for the invitation to be here and be part of this important discussion today. I'll be giving an overview of neural tube defects and discussing their global prevalence. Next slide, please. This is the outline that I'll be following by my talk. For my talk, I'll begin by defining what neural tube defects are, or NTDs, as you might hear me call them, and that's not to be confused with neglected tropical diseases, which is also another term that many might be familiar with. I will describe what they are, talk about the most common types, and then move a little bit into discussing mortality and morbidity. Then I'll talk about the global prevalence and touch on some of the major data limitations around that, and then end by briefly discussing risk factors. Next slide, please. So what are neural tube defects? Neural tube defects are serious birth defects of the brain and spine that occur when the neural tube, which will ultimately develop in the baby's brain and spinal cord, does not close properly. Development of the neural tube begins in the first days after conception, and it's completed by day 28 of gestation. So in the left image here, you see an embryo at day 22 to 26 of gestation. In this image, the neural tube is already in the process of closing. You can think of it like a zipper that kind of zips up the back. The small window of time of neural tube formation and closure is really critical to note, as is often before a woman realizes that she's pregnant or knows that she's pregnant. And as you'll hear more about in the following presentation, any intervention to prevent neural tube defects must happen before this time of closure. As illustrated in the center of the slide in panel C, there are several types of neural tube defects, and the level of lesion along the neural tube will determine the type and the severity of the neural tube defect. Next slide, please. The three most common types of neural tube defects account for almost all neural tube defects, and they're shown here. The first is anencephaly, with the characteristic total or partial absence of parts of the brain and skull. Then there's spina bifida, in which there's a lesion located along the spinal cord that could be open, like the one that's shown here in the image, or it may be covered with skin. And then there's encephalocele, in which there's a sac-like protrusion through part of the skull. Spina bifida is the most common type of neural tube defect across the world, accounting for about half of all neural tube defects. And then anencephaly is the next most common, accounting for about 40% of all cases. But it's important to know that these percentages are from pooled estimates from the European Surveillance of Congenital Disorders Monitoring Network, or EuroCat. And while these are regional estimates globally, in countries where women's blood folate status is extremely low, the proportion of anencephaly cases is actually potentially much higher. Next slide, please. Neural tube defects are a major contributor to infant mortality and morbidity across the world. Looking at the mortality of the two most common types of neural tube defects, anencephaly and spina bifida, anencephaly is incompatible with life. It's always fatal. But on the other hand, the survival of babies born with spina bifida varies greatly depending on, as mentioned previously, the location and the severity of defect, and also on factors like the availability and quality of medical care. A study in the US found that in New York State, 12% of babies born with spina bifida died before their first birthday. And in a cohort in Dublin, Ireland, infant mortality was 50%. Mortality is reported to be even higher in developing countries. For those children with spina bifida who do survive, they'll have varying degrees of lifelong disability. For instance, most children affected by spina bifida experience lower extremity weakness and orthopedic problems, which may need surgery or bracing. They can experience loss of bladder and bowel control and might develop significant renal disease. Hydrocephalus is a common secondary complication, and risk for infections are increased. And many children with spina bifida have abnormalities in brain development, which results in learning and developmental disabilities. However, the good news is that babies who are born with spina bifida who receive proper interventions and accommodations, such as surgery or assistive medical equipment, can often live full and productive lives. And you'll hear more about this in the following presentation. Next slide, please. Neural tube defects are one of the most common types of birth defects across the world and can occur widely across different geographical areas, in countries at all levels of economic development, and among diverse population groups. The March of Dimes Global Report on Birth Defects in 2006 was the first major study to estimate the magnitude of the problem globally, and they estimated that there are about 300,000 live births with neural tube defects each year. But as depicted in the image here, this is really just the tip of the iceberg and doesn't show the largely hidden burden. Data are very limited globally due to a lack of birth defect surveillance and registries, and even where these systems exist, the prevalence of birth defects is often under ascertained due to factors such as limited resources, diagnostic, legal, and cultural barriers to capturing stillbirths and elective terminations of pregnancy, and the difficulty of capturing early pregnancy losses, such as spontaneous abortions. Next slide. In a systematic analysis that was published this year, Blenko and colleagues built on the methodology the March of Dimes used in their 2006 report to generate updated global and regional prevalence estimates to provide uncertainty intervals around these and to better detail the methodology that they undertook to come up with these estimates. They examined all the available birth defects registries and monitoring networks, as well as conducted a review of published literature to capture data to put into their model. They identified birth defects registry data from 39 countries that met their inclusion criteria, but only data from 24 countries were considered to be able to be generalizable to the whole country and used directly in national prevalence estimates. For the remaining 171 countries without recent registry data meeting inclusion criteria, neural tube defect prevalence was estimated based on a meta-analysis of all the available data, and then they developed pooled regional prevalence estimates. The authors adjusted for the lack of global data and other data limitations to the extent possible. And with this in mind, they estimated the figures that are shown on the screen here. They estimated the global burden of neural tube defects to be just over 260,000 neural tube defect affected birth outcomes, and this includes live births, stillbirths, and elective terminations of pregnancy. They estimated the prevalence of NTDs to be about 18.6 per 10,000 live births, and they estimated that approximately 90% of neural tube affected births result in mortality by age 5, and about half of these are affected pregnancies and before birth as stillbirths or either as elective terminations. With these numbers in mind, it's important to recognize that they truly are, as we just discussed, the tip of the iceberg. The authors state that even with the pre-modeling adjustments they made, quote, challenges in tracking pregnancies and the consequent paucity of data make it impossible to estimate NTD-associated early fetal losses and miscarriages. And furthermore, many of the data used lack representativeness, and the model was based on a lot of assumptions just purely because of the lack of global data. As such, the authors state these estimates represent an underestimate of the total number of NTD-affected pregnancies. Next slide, please. And I just wanted to touch briefly on the risk factors for neural tube defects. The exact causes of all NTDs are not known, but we do know of several different risk factors that are involved. Nutrition, environmental factors, maternal behaviors and conditions, and genetics are all known to play a role, including those factors listed here on the slide. And of these risk factors, folate insufficiency is of special importance. And with that mentioned, I'll turn it over for Dr. Lynn Bailey's presentation, as that's one of the main topics of her presentation. Thank you.
Thank you so much, Amy. Really appreciate your providing the context and background for neural tube defects, our main point of discussion for today. Before we move on to Lynn, we did have a question that came in for you, Amy. It says that you mentioned that with both the March of Dimes and the Blenko report and the Blenko study, that there's an underestimation of NTDs globally. Is there anything that CDC is doing to address or help address this underestimation?
Sure, I'd be happy to talk about that, and thank you for the question. As mentioned in my bio in the introduction, CDC has an initiative called Birth Defects Count, Countries and Organizations United for Neural Tube Defect Prevention, which aims to decrease morbidity and mortality from NTDs across the world. And one of the primary ways that we're doing this is working to establish and strengthen high-quality surveillance across the world so that that information can be used to drive policies such as fortification policies. And we do this both in the areas of birth defect surveillance and biomarker surveillance. For birth defect surveillance, we've worked closely with WHO and the International Clearinghouse for Birth Defect Surveillance and Research to develop a comprehensive toolkit of how to conduct birth defect surveillance in low and middle income countries. This is available online, has several web-based modules and trainings, and it has a manual for program managers, a photo atlas of the birth defects to be captured, as well as several other tools. We also work with these partners and others to conduct trainings and build capacity in different regions of the world. Our efforts are greatly focused right now in Southeast Asia and East Africa because this is where much of the burden of neural tube defects is. And in addition to supplement what we're doing with birth defect surveillance, since we'll still be limited in some senses by some of the difficulties and limitations I mentioned with regards to capturing some of those early pregnancy losses. Something we'll hear more about as the discussions go on is measuring women's blood folate status. And so we're supporting work across the world to increase capacity to use that as a way to supplement the data that we're getting from birth defect surveillance and understand the risk of the population.
Thanks so much, Amy. I appreciate that answer, and I know our participant does as well. We do have a few more questions that have come in for you, but we'll hold those for the discussion at the end of the webinar. Over to you, Jessica.
Great. Thanks again, and thanks, Amy, for that. Our next presenter is Dr. Lynn Bailey. Dr. Bailey is professor and department head for the Department of Foods and Nutrition at the University of Georgia in the US. Over the course of more than 30 years, Dr. Bailey has conducted human metabolic studies to determine how much of this vitamin is required to maintain optimal status as assessed by biomarkers for individuals of all ages, including pregnant women and the elderly. She has served on a large number of advisory panels, including the FDA Folic Acid Advisory Committee, whose recommendation led to folic acid fortification of the US and Canadian food supply. As a member of the Institute of Medicine's committee that revised the dietary intake recommendations for folate and other B vitamins, and has a long-standing collaboration with the US CDC, contributing to global efforts to assess folate status as a basis for folic acid fortification programs to reduce the risk of neural tube defects. Dr. Bailey chaired the NIH Biomarkers for Nutrition and Development, BOND, folate panel, and served as chair of an international Bill and Melinda Gates Foundation supported initiative through Nutrition International and the Micronutrient Forum to develop an evidence-based roadmap delineating how to best prevent NTDs with folic acid interventions globally. Thank you, Lynn.
I'm happy to provide a brief overview of folate status and neural tube defect prevention. Next. First, the question, what is folic acid? Well, folic acid is one chemical form of the vitamin folate, and it's an essential nutrient that cannot be synthesized by the body, and it must be consumed in the diet or in supplements. And folic acid is the form in supplements and in folic acid fortified foods. Next. The functions of folic acid include DNA synthesis and methylation, and both of these are required for cell division and gene regulation for both growth and development. Next. And as we have just learned, neural tube defects develop in the spinal cord and the brain. And when the spinal cord is developing, this is in the first 28 days of gestation, when the majority of women do not know that they're pregnant. And then the neural tube continues to develop into the brain. Next. Again, as a recap, two major kinds of neural tube defects include Spina Bifida and anencephaly. Next. There is a large body of research evidence that proves that folic acid prevents neural tube defects. This table summarizes the key data, including the Medical Research Council gold standard study, and it's gold standard in that it definitively proved that folic acid and folic acid alone will prevent the majority of neural tube defects. Next. This definitive research evidence led to the folic acid neural tube defect public health policies globally. These include the recommendation that all women of reproductive age consume 400 micrograms of folic acid daily, and also the policy of folic acid fortification of cerebrain products, which is a current policy in 81 countries. Next. What are the key folate status indicators? Serum folate is very responsive to recent dietary intake. And in contrast, red blood cell folate concentration is a very sensitive biomarker of longer-term folate status. And it is the only biomarker linked directly to neural tube defect risk. Next. These figures illustrate the dramatic increase in both serum folate and red blood cell folate in response to folic acid fortification in the US, which began in 1996. Next. This figure illustrates the dramatic drop in neural tube defect rates in the US in response to folic acid fortification, again, which was initiated in 1996. Next. In addition to the US, neural tube defect rates have dropped significantly in countries with mandatory fortification, as illustrated by this data from select countries shown in this figure. Next. WHO has established that red blood cell folate is directly associated with neural tube defect risk. Optimal red blood cell folate was defined by WHO as 906 nanomoles per liter, and this is a blood concentration that should be exceeded to achieve the greatest reduction in neural tube defects. This WHO guideline for optimal blood folate is meant to be used to assess folate insufficiency in populations, not individuals. And the assay of choice is the microbiological assay. Next. The WHO guideline is predominantly based on an Irish case control study. And this is demonstrated in this figure, which shows an estimated neural tube defect risk per 1,000 births. And this is in relation to red blood cell folate concentration. You can see to the left in the very low red blood cell folate concentration range that the rate of NTDs is very high. It continues to go down throughout the normal red cell folate concentration until the concentration reaches 906 nanomoles per liter. And then there's a plateauing or leveling off of NTD rates. Next. CDC has established that the microbiological assay is the most reliable method to obtain comparable results for red cell folate across countries to assess NTD risk within a specific country. For global assessment of NTD risk, there's a need to harmonize the microbiological assay, and this is through consistent key reagents and procedures in selected global regional laboratories that are conducting the red blood cell folate analysis. Next. The WHO guideline is used to estimate the percentage of women of reproductive age in a population who are folate insufficient. And this means that this percentage of the population of women of reproductive age are at increased risk of having an NTD-affected pregnancy. And to utilize this WHO guideline to estimate NTD risk in low and middle income countries, red blood cell folate in women of reproductive age should be determined with a microbiological assay. Next. What is the global folate status of women of reproductive age? A systematic review evaluating folate status of women of reproductive age globally based on serum and red cell folate has recently been published. The results indicate that there are very limited data on folate status of women of reproductive age using cutoffs appropriate for the type of assay used. There is also a disproportionately large gap in data from low and middle income countries. Next. So in conclusion, red blood cell folate is predictive of NTD risk, defined as folate insufficiency in population groups of women of reproductive age. And there are limited data on folate status in low and middle income countries. The microbiological method is recommended, and due to methodological differences, there is a need to harmonize the microbiological assay to enable comparisons within and between countries and regions. Next. Thank you very much. I'll be happy to answer questions.
Thank you, Lynn. That was very informative. And we do have a number of questions that have come in from participants. At this time, we'll have time for one or two, and we'll hold the rest for the end. If participants do have any additional questions, please send them via the chat mode. We'll keep everyone muted just to be able to move forward with a smooth webinar, but we will be taking questions throughout the entirety of the webinar, and again, be able to address as many as possible at the end. So Lynn, to you, the first question is, will folic acid fortification programs affect all women of reproductive age equally, or are there groups of women that might need more targeted approaches?
That's an excellent question. And the answer to that, in low and middle income countries, there are likely pockets of women that will not be reached as effectively as other population groups. For example, in Guatemala, out in the very rural areas, the indigenous women had less access to fortified food products. Also, they were less affordable for the very low socioeconomic category. So to answer the question, no, there's an uneven distribution of fortified products in low and middle income countries. And in those situations, there is a need for a more targeted approach to reach these women who are at great risk.
Thank you, Lynn. And I do think we have time for one more question for you, which is a question that will actually set up our next presentation quite nicely. Can you speak to any adverse effects of folic acid that need to be considered before moving ahead to recommend folic acid fortification?
That's also an excellent question. And this question has been embraced by the Food and Drug Administration in the US and by a safety advisory group in Europe. And after a course of years and bringing together groups of experts related to folic acid and any potential negative effects, the conclusion from both of these expert committees, and this has been published in a number of publications, is that no, there are no demonstrated adverse effects of folic acid. And in fact, for example, the question of whether folic acid might increase cancer risk, if you look in the US, which, and this has been carefully evaluated, colorectal cancer, for example, the rate actually has progressively declined post-fortification. So as we saw the blood folate concentrations increase post-fortification, we saw cancer rates decline as one example. So the answer to the question, no demonstrated evidence of negative effects of folic acid.
Thank you, Lynn. I appreciate your very thorough answer to that question. And we'll move on to the third presentation now in our science section. Over to you, Jess.
Thank you. Next up is Mr. Scott Montgomery. Scott is the director of the Food Fortification Initiative, a public-private civic partnership helping countries promote, plan, implement, and monitor industrial milled grain fortification programs. He brings 30 years of cereal grain industry expertise to the leadership position, having worked for Cargill Incorporated from 1980 to 2010. Working in the wheat flour milling business in North America and global operations for Cargill's wheat and maize milling operations, and ultimately citrus operations in every region of the world. He retired from Cargill in 2010 as vice president, global procurement leader, and joined the FFI staff as the industry liaison, going on to be named FFI director in 2011. Over to you, Scott.
Thanks, Aleki and Jessica, for inviting me to present on this with this esteemed group. Special thanks for those of you across the ocean that are staying up late to listen to this. It's my pleasure to talk to you today about one of the most effective ways of increasing the population's folate intake. That is fortifying grains with folic acid. Next slide. So the current status, there's 62 countries that have mandates that require adding folic acid to one or more grains. In Costa Rica, the US, most wheat flour maize flour, and rice are all fortified with folic acid. As you can tell by the map, it's more common for countries to fortify 1 or 2 grains. In many parts of the world, we feel that fortifying rice is an untapped opportunity that we're working on hard just in the last few years. Next slide. So why fortify cereal grains with folic acid? As most of you know, supplements work, although the uptake of supplements, the studies show it's not the most effective approach to preventing neural tube defects. Why is that? Why is grain a good option? People consume additional folic acid without any change in behaviors. They simply eat the staple foods that they always do eat. Women increase their folic acid intake even if they're not planning a pregnancy. You heard comments about that in both Amy's and Lynn's presentation, that the neural tube closes before you often even know that you're pregnant. And thirdly, the third advantage to food fortification is the private sector already delivers the food to the consumers. You don't have to create a new delivery program. Next. I won't spend a lot of time on this slide. Lynn already presented a lot of this data. What does it say? Indisputable data. This works. If you fortify grains with folic acid, you're going to reduce neural tube defects. Next. So globally, an estimated 50,000 neural tube defects were prevented in 2017, an average of 138 per day due to fortifying flour with folic acid. Next. From my background, we always talk about payback, the return on investment. The story for fortifying cereal grain with folic acid is quite incredible. You can see on the slide in Chile, the estimates were annual savings of 2.3 million. In South Africa, annual savings of 5.3 million. And in the United States, a recent study, 603 million. Again, in my background, we always talked about return on investment or payback. So in the case of the United States, for every $1 invested in folic acid fortification, today we estimate with increasing healthcare costs that there's almost a 100-fold savings in healthcare expenditures. It's absolutely incredible story. Next slide. So we celebrate the neural tube defects prevented, but you can see on this map, we have an opportunity to do much more. And I want to move on to a short discussion about India. India, the estimates are up to 100,000 of those neural tube defects per year. And so I think it's worth highlighting India for just a moment, because we are working on a current project in India that we're quite optimistic about. Next slide. So this project is in Haryana state, which is in northern India, where wheat consumption is more common than rice. It's also a state where about 2,400 children are born annually with neural tube defects. If you apply the national prevalence of 41 neural tube defects per 10,000 live births. As with many other states in India, the anemia prevalence and vitamin B12 deficiency is also high in Haryana, and the flour is being fortified with those nutrients as well. But for today's topic, I'll only talk about folic acid. Next. So the government's been distributing wheat kernels in the public distribution system, so they've been distributing grains. The beneficiaries then have to take the wheat to a local flour mill to have the kernels ground to flour. We studied the wheat supply chain in Haryana and found that the state had a capacity to produce and distribute fortified flour and not increase the cost for the public distribution system recipients. The first fortified flour was distributed in March 2018 in 2 parts of the state, Naranjgara and Barara blocks of Ambala district. on an average, around 1,000 metric tons of fortified flour called ATA is distributed every month in those 2 blocks. It's distributed through the existing 40 fair price shops. It reaches almost 170,000 beneficiaries. Next slide. So the next steps are to scale up to the rest of Haryana, then other states in India. Reaching all of Haryana will require 50,000 metric tons of fortified flour each month. My background is milling. That's a large amount of flour. And that incentivizes the private sector to invest in producing the fortified flour. Some mills have already added equipment to do this. There's a photo at the right. And ultimately, our goal in Haryana is to reach 12 million beneficiaries. Beyond that, this is a strategic approach to fortification. You heard me say that it's cost neutral to the government if it's done properly, and we're anxious that we'll be able to replicate this model across many states in India. The other, I've engaged several people that I notice are on this call. The Food Safety Standards Authority of India had just modified their cereal grain fortification standards, which are a bit worrisome for us. So we've engaged all of the local people in India as well as the global experts to try and convince the Food Safety Standards Authority of India to reconsider those wheat flour fortification standards. The biggest problems are in folic acid and vitamin B12. Next. So to conclude, fortifying flour with folic acid is a proven strategy for preventing neural tube birth defects, but it's not being fully utilized. Thank you.
Thank you, Scott. I really appreciate your comments, and we've had several questions that have come in from participants. I think we'll have time for 2 right now, and then we'll move on to, we'll save the others for the general discussion at the end. This is from a participant, why, in your opinion, have certain regions, such as Europe, been so slow to implement fortification?
I wish I had a succinct answer to that with a meta-analysis, but I can give you some anecdotal comments on that. One, it's a cultural thing. If you talk about GMOs, you talk about a lot of things such as that. There's just an aversion to adding things to our food or changing our food. And we're working on that. We're optimistic in the UK right now. There's an effort actively going on to add folic acid. We feel that would be a huge milestone in that journey. There are neural tube defect problems in much of Western Europe. I would cite Germany as one of the targets that we've been trying to push forward with. The mills are very automated, state-of-the-art mills. It could be easily done, but it's just getting that past that cultural aversion to do so. The other challenge in many countries in Western Europe is the neural tube defect of fetus is detected like at the end of the first trimester, and those children are simply terminated. Our view is termination is not a prevention strategy. It's a very traumatic experience for a young lady that's become pregnant, starting to show that child is growing and then realizing there's a neural tube defect and simply terminating that life. So again, we just don't feel that that's a good prevention strategy.
Thank you, Scott. The second question that's come in is about voluntary versus mandatory fortification. The question is voluntary as good as mandatory? Sometimes that seems to be an easier sell.
Voluntary fortification over and over again across the world has proven to not be an effective strategy. We simply do not even push forward with efforts to convince millers to voluntarily fortify. I can speak from that from my own personal background. The milling industry is not computer chips or high margin products. It's a very thin margin in the milling business. And when you add $1 to $3 per metric ton to the cost of flour, that's going to consume the majority of your margin. And you simply, I know my experience in India when I was working there with Cargill, that was a loss leader, atta flour as an example. We simply did not make much, if any, money on atta flour. And then to ask the private sector, well, why don't you voluntarily fortify? It just doesn't work. The second thing is that particularly the population that most needs fortified flour or rice, they're very price sensitive. So if a miller is going to try and recover that cost of fortification in a voluntary program, they're going to have to raise the price. If a consumer looks at one bag next to the other, one's cheaper, they're going to buy the cheaper bag.
Thanks, Scott. I really appreciate your extensive knowledge and experience with that, especially bringing forward the industry perspective. We'll move on now to our next presentation. Over to you, Jess.
Thank you, Scott, for that. Our next presentation is by Dr. Homero Martinez. Dr. Martinez is Senior Technical Advisor and Team at Nutrition International. Homero joined Nutrition International in 2016 as Senior Advisor to the Micronutrient Forum, MNF, where he was responsible for steering the activities of the MNF to follow its strategic plan and address key barriers to achieve micronutrient adequacy for individuals and populations. He has ample experience in public health nutrition, specifically addressing different forms of malnutrition in vulnerable populations, including young children in developing countries, and focuses his research on several micronutrient deficiencies, including iodine, iron, vitamin A, and zinc, as well as interventions to address the overweight and obesity epidemic, nutritional and hydration management of children with acute diarrhea, and several other health and healthcare related areas. Homero serves as Senior Advisor for Nutrition International's Folate Secretariat, the Folate Task Team. Thank you, Homero.
Thank you very much. Just can we have the first slide, please? So as we have heard, there's clear evidence that improving folate status of women of reproductive age before they get pregnant will help prevent the majority of neural tube defects. However, there's still several challenges to address, including, as Lynn very clearly pointed out, the limitation or the very limited data that we have, especially in low to middle income countries, about folate status. And this is very much tied to the difficulties in having access to properly trained laboratories around the world. The monitoring of neural tube defects has also been highlighted. And as the previous two presentations have shown, effective ways to delivering folic acid to hard-to-reach populations is also a hindrance to our success. Next slide, please. So to address some of these challenges, Nutrition International has secured funding over the past several months from the Bill and Melinda Gates Foundation, which has allowed us to establish a working group, including a lean secretariat based here at Nutrition International, very strongly supported around the globe with an expert advisory group with a true multidisciplinary composition, and a wide reach of interested partner organizations and other stakeholders to help develop, coordinate, and prepare for the future implementation of a global action plan. We have continued to facilitate access to scientific and technical conclusions of a recent consultation convened by the Micronutrient Forum, to which Aliki and Jessica alluded on previous interventions, for the purposes of planning, implementing, and evaluating neural tube defect prevention programs. Part of these activities are supported by this webinar. We are in the process of conducting a landscape analysis to serve as the basis for identifying countries where future advocacy and support will serve as a model program development that can later be adopted or scaled up to other countries. Next slide, please. we have teamed up with the CDC in the US to support the capacity building in selected low to middle income countries to assess folate status, taking the first steps to establishing a global network of regional labs. During the current grant period, we have identified 4 regional labs plus 1 national lab, which are in the process of sending their trainees to the CDC. We're actually very excited. The first training is taking place this week. The second wave of training will take place the following month. So within 2 more months, we will have actually 10 trained lab personnel in 5 labs around the world who will be properly conducting the microbiological assay to determine red blood cell folate. This will greatly help to increase the database for folate status around the world. The CDC has done a wonderful effort in producing a training video accompanied by a manual, which will shorten their training time from 2 weeks to 5 days. And this will soon be available for other people to access in a very open access fashion, including the training video and the manual, both in CDC's website as well as in the Folate Task Team's website. And this will set the basis for a future global network of regional labs, which is attempting to have 2 trained labs in each of the 6 WHO regions around the world. We are also supporting folate relevant research, trying to identify on the one hand actual region coverage of mandatory fortified staple foods, and on the other hand to identify what may be the predicted coverage of alternative food vehicles or other food staples, which may help to reach these hard to reach populations that Lynn alluded to during her presentation. Next slide. I briefly want to give you an idea of the structure of the Folate Task Team. As I mentioned, there is a Lean Secretariat with a project lead, a knowledge translation officer, and a project consultant. We have been hosting this seminar. A core working group coordinated by Lynn and supported by 2 other experts to complement her expertise with the fields of epidemiology, birth defect surveillance, and programmatic experience. As I mentioned, a very multidisciplinary group of 7 individuals who bring together expertise from laboratory training, capacity building, birth defect surveillance, pediatrics, nutritional program implementation and technical assistance, as well as advocacy and representation of affected populations, and of course, food fortification and policy. We're further supported by 4 ex officio members, as well as 4 as-needed advisors, and the invaluable collaboration of a senior CDC scientist. And we further extend our reach to stakeholders and partners, many of whom are present in this webinar. Next slide, please. And we try to reach out to the larger public through our webpage, which you can see on screen, in which we not only keep update of our work, but we also try to highlight recent publications, recent activities which are relevant to the field, and to look at future activities which may also help to augment our capacities and our reach and impact. Next slide. I thank you all for your attention, and I will be very willing to take 1 or 2 questions if we have the time. Thank you.
Thank you, Homero. I really appreciate you really shaping the work that's been done over the last couple of years, as this is such a unique effort, bringing birth defects and nutrition together on a global scale. We do have time for 1 question, and we'll save the others for the end. This question is, I hear mixed information about there being benefits for men taking folic acid and there being an impact on reducing NTDs. Can Dr. Martinez offer any information on this?
As Lynn pointed out when reviewing the biology of folic acid, or folate actually, this B vitamin is involved in every process in which cells are actively reproducing themselves. So men, of course, have cells which are reproducing at a high rate, especially linked to the reproductive period. So folate does play a role in fertility and in a healthy reproduction from the point of view of the male contribution. It does not affect specifically birth defects from the contribution of folate into men's diet, but there is no drawback from including men as part of the target population or as part of the larger benefited population when using population-based strategies like large-scale food fortification.
Thank you, Homero. I appreciate that. We'll be turning now to the second portion of our webinar. I want to thank Amy, Lynn, Scott, and Homero for providing informative set of presentations that gave us the scientific underpinnings for the next group of speakers. We'll now hear from respected colleagues from Ireland, Uganda, and Argentina who share with us the country context for creating a better life for everyone. Over to you, Jess.
Thank you. I would like to introduce Mr. Tom Scott. Tom Scott is the CEO of Spina Bifida Hydrocephalus Ireland, SBHI, the national organization for those living with spina bifida and/or hydrocephalus. With over 15 years experience in social care and education settings, Tom has worked and volunteered for charitable organizations including Deafblind UK, the Corpse Trust, Soapbox, and the Peach Haven Trust. Tom is a board member with the International Federation for Spina Bifida and Hydrocephalus, School Makua, and the Neurological Alliance of Ireland. Tom is passionate about the rights of those living with disabilities and seeks to facilitate progression in this area at every opportunity through his role with SBHI, IF, and School Makua. Over to you, Tom.
Thank you, everybody, and thank you for everyone who's spoken so far. I'm just going to speak a bit about the Irish context. Next slide, please. So Ireland has one of the highest rates of spina bifida and neurotube defects in the developed world. And there are around 80,000 children born in Ireland each year. So here we have around 30 to 40 births affected by spina bifida each year, and that represents around 1 in 2,000. It's estimated there are between 1,000 and 1,500 people in Ireland living with spina bifida, and that's because the medical innovations to save babies who were born with spina bifida came in the late 1960s, and there's just been a growing cohort ever since then. In Ireland, 65% of people who live with spina bifida also have hydrocephalus, which is why we work with the two conditions. And hydrocephalus is present in 1 in 1,000 live births in Ireland, and this would be a kind of a growing area of work for us to respond to. And I believe that's largely due to our success rate in saving premature babies. The spina bifida specifically, the high rate is due to what they call the Celtic gene, so just a predisposition to people in this region developing certain conditions. Limited practice of termination to date, but that is soon to change. And I'll talk about that in a minute. Poor awareness of the benefits of taking folic acid, and then actually poor awareness of when to take folic acid as well. And there's limited action from the government in terms of taking action to address NTDs. Next slide, please. So what action has been taken typically over the last few years? The government delivers its public health messages via an agency called Safe Food. And Safe Food has a very wide remit in terms of covering all aspects of public health, which means that sustained campaigning isn't really an option. And typically this means that you see a 6-week campaign every year or every 2 years, and then it goes away again. And this isn't ideal for us, obviously. As an organization, SBHI has fought to be more involved in the preparation and dissemination of these messages. However, this has been, has seen limited access, and the messages are often dictated to us at a very late stage in the development of these public awareness campaigns. In the past few years, Safe Food have relied heavily on the resources generated by Shine. These were made prior to 2015 when I worked at Shine myself, and I worked there with Martine Austin, who many of you will be familiar with. Next slide, please. So there is a bit of a change in the Irish context in that on the 26th of May 2018, the Irish people voted in a referendum to change the constitution concerning the legalisation of abortion in some circumstances. This was known as the Repeal the Eighth Movement, referring to the relevant amendment in the Irish constitution. And it was won by a vote of 66.4% to change the constitution with a record turnout from the electorate. The government are working to have the relevant legislation passed by the end of 2018. And the statement they make is that the government will shortly begin work on passing the draft of the proposed law, which will allow for abortion without restriction up to 12 weeks and in limited circumstances after that up to 6 months, which could obviously have large implications for Spina Bifida. In terms of fortification, it isn't really on the agenda of the Irish government at present in any serious way. However, as one of the previous speakers alluded to, if the UK do go ahead with fortification, as we believe they will, we think that Ireland and many other countries in Europe will look at the issue more seriously and will start to make some more concrete plans around that. Next slide, please. So Spina Bifida, Hydrocephalus, Ireland and prevention specifically, we have been involved in folic acid awareness raising initiatives in the past, but the promotion has been limited and it only really amounts to short campaigns and information on our website. And we do as an organisation have significant issues around the messaging in terms of members who take objection to the folic acid message, either because the mother didn't take folic acid or did take folic acid and it didn't prevent their child having spina bifida, or because they did take it and they feel blamed for their child having spina bifida. So we have to deliver those messages very carefully. We are currently, however, working on a new website and promotional campaign with a GP, a doctor here, who is keen to promote the folic acid message, and this will launch in 2019. And we did, in collaboration with the International Federation, produce their current folic acid awareness leaflet, and that's the same one that we use in our context as well. Next slide, please. I just added this slide here around communication and prevention. You know, as an organisation working closely with individuals who live with spina bifida hydrocephalus and their personal networks of families and friends, we do struggle with communication around prevention because it's such a sensitive area. It's very difficult to promote campaigns which include terms such as prevention and defect, whilst at the same time advocating that we support those living with the conditions to live the most fulfilled lives possible. I'm not saying that these are incompatible messages, it just has to be done with a lot of sensitivity, and this means that it can take some time to get something going. And I think in this context we have to be very cognizant of the intersection between the scientific arena and that of the lived experience of those who are born with spina bifida and those that support them. And I think we can do more on language around the communication of this in terms of being more subtle with using phrases such as working to increase awareness, which offer similar a message to that of working to prevent NTDs. And I often wonder, you know, way back when, if we could have called it a neural tube exception rather than a neural tube defect, it would have been helpful in this context. Next slide, please. Thank you. So that is my contact details. Thank you for giving me this opportunity to speak. And if there's time or if there are any questions, I'll be happy to answer them.
Thank you, Tom. We do have time for one question. We've had two come in, but we have one that we'd like your thoughts on. And it's about the last slide that you presented on communication. It is, you really struck a chord with your final remarks about the importance of communication, even nuanced communication. What other tips can you share with us around how best to communicate? And can you share any resources or forums where we can be better in touch and connected?
Sure. So I guess I can only go off the experience I had when I worked at Shine in the UK, and the approach we took there was actually not to get bogged down in a lot of negativity and to keep the campaigns actually very fun. So we used a lot of joking around targeting a primarily, obviously, female audience and the link between that and sex and what have you. So we had an animation that featured a character who was an animated folic acid tablet, and we had a poster with a kind of a slogan that engaged the female audience. And, you know, when you work like that, you do get a mixed response because, you know, you can't please everybody and some people don't like that sort of approach. But we were very conscious that, you know, 50% of pregnancies in the UK and Ireland are unplanned. And so we're all the time trying to target a very wide audience. So that's one approach. The other approach that I want to pursue now I'm here in Ireland is actually to get into the education curriculum and have it as part of either sex education or the relevant biology topic, so that young people are learning about this right from the beginning, and that we don't have to do all the hard work once they're out there in the world, if you like, and sexually active, that actually it would just be something that they understand as well as they understand contraception.
Thank you, Tom. I appreciate you sharing those examples. And I'm sure if others have questions, they can contact you directly via your the details on the screen. We have had a slight technical glitch with our next speaker, so we're going to change the order and move on to hearing from our last speaker, and hopefully we'll be able to correct this before the end of the webinar. Over to you, Jess.
Great. So our next speaker is Elena Monzon de Záppoli. Elena is a mother to a son, aged 40, who was born with Spina Bifida and Hydrocephalus. Since his birth, Elena has dedicated her life to learning, educating, and helping families with children with Spina Bifida and Hydrocephalus in APEBI, Asociación para Espina, Bífida y Hidrocefalia, Argentina. After volunteering for APEBI for decades, she is currently its president, serves as a board member for the International Federation for SB&H, and represents the Americas in IF as well. Elena is responsible for coordinating a strategy aimed at setting up support groups in Latin America and the Caribbean with the help of APEBI's team of the International Federation for SB&H and Child Health International. She was recently selected by the government to be the National Director of the Observatory of Persons with Disability, UN Convention on the Rights of Persons with Disabilities. Thank you, Elena, for being here with us today.
Thank you very much for having invited me to participate in such an interesting webinar. I'm glad to share with so many people from all the world some successful experiences that our association, Asociación para Espina, Bífida y Hidrocefalia, has had this current year. The next, yes, prevention campaign. Well, here you can watch, yes, a prevention campaign launched on the World Spina Bifida and Hydrocephalus Day. Let's watch it.
Tener un bebé saludable significa que vos también te preocupes por estar sano.
El ácido fólico es una vitamina muy importante antes y durante el embarazo,
porque puede prevenir malformaciones congénitas en el bebé.
El ácido fólico se encuentra en algunos alimentos que consumimos,
pero eso no es suficiente para mantener los niveles que recomiendan los médicos.
Por eso es muy importante tomar una pastillita de ácido fólico todos los días.
Desde 3 meses antes de quedar embarazada hasta el 3er mes de embarazo.
Si vivís en la ciudad de Buenos Aires, tenés que saber que ahora hay una nueva ley que garantiza la entrega de ácido fólico de manera gratuita en todos los hospitales públicos de la ciudad. Si querés saber más, llama a la línea gratuita 0800-222-3328. Somos APEBI, Asociación para la Espina Bífida e Hidrocefalia. Estamos para ayudarte.
The lady that we consider is a very well-known journalist in our country. This campaign aims at promoting primary prevention through folic acid and raising awareness of folic acid intake. This video is shown everywhere from the whole country, from the north, south, east, and west. And well, it is the way where we can reach to every home by TV. The next. Here, this is an achievement in the following is a law that has been passed guaranteeing free folic acid in public hospitals in Buenos Aires City. And here Marisol is going to read our first law.
This law is intended to guarantee free folic acid supplementation or the medicine which replaces in the future for all women of childbearing age trying to get pregnant, who make an OB/GYN and preconceptional appointment, pregnant women, and women who doubt whether they are pregnant until 14 weeks of amenorrhea. Create raising awareness campaigns about the importance of folic acid intake in the preconceptional period and during pregnancy in an effort to promote NTD, neural tube defects, and anemia prevention, and provide health benefits. Section 2, free provision is mandatory at every public healthcare center in Buenos Aires City. Section 3, the implementing and enforcement authority is the Ministry of Health of Buenos Aires City or the given agency which replaces in the future. In Section 4, the Ministry of Health of Buenos Aires City shall introduce every measure to enforce this law.
Yes, and now some lawmakers are trying to make it a national law, a project which is likely to be successful. Thank you for all your attention.
Thank you so much. I really appreciate hearing from you and seeing the campaign. We will try to, the campaign video will be included when the presentations are posted on the website, and we'll ensure that there will be sound available to the best of our ability. So we hope that folks will be able to view that privately. We want to thank you, Elena, for bringing the women's voice to the table as well. And we do have a number of questions as we segue into the general discussion. First, we've had some comments that your app idea looks really great, and there's congratulations going out to you, Elena, for that. And we also want to share that people who'd like to work on prevention campaigns can also connect with the IF Global Prevention Initiative, which is the responsibility of the program manager in global prevention, Martine Austin. So we'll share her contact details also following the presentation when we post the full slide sets and other contact details on the website. I'd like to now move into our final 20 minutes as we to hear from hear some additional questions and have some more discussion with our speakers. Unfortunately, our final speaker from Uganda, we're unable to move past the technical difficulty that we're having. We do have her slide deck, which we'll include in the materials post-webinar, and we'll make sure to get her talking points to include as well, and her contact details for any further information. So we do apologize for that, that difficulty, but we'll make sure that her voice and her viewpoint is heard as well. So moving into the general discussion, we'll move through some questions that have come through, and I'll, to the best of my ability, address them to specific speakers. And at the end, we will hear from Dr. Martinez. We'll hear some closing remarks before we conclude the webinar. So let's first move to, and this would go to both Tom and Elena. So we'll go to Tom first, and then Elena, you can add additional thoughts and perspectives that you may have. It's a question about advocacy and including representatives of the civil society. So should they accompany the institution of the states when we're talking about implementation and the process of prevention? So it seems that this question is really about including civil society, their role, and the importance of having them included. Tom, over to you first.
Yeah, it's an interesting perspective. I guess the ideal in the way that we all work is that we would have as diverse a group as possible in these working groups. I can't honestly say that we're that far along here in Ireland yet. So there will be work between ourselves, the doctor that I mentioned, and some of the companies that produce the folic acid supplements commercially. But I do like the perspective that we would introduce somebody to have a civil perspective on that. So my honest answer is that we haven't actually done that, but I can see the merit in it, and I will actually adopt that idea into what we take forward, because I guess it's very easy for us in our very concentrated perspectives to be concentrating on Spina Bifida and to be in our own world in that sense. And it would be good to engage people with a wider view. Presuming that I've interpreted that question correctly there, Jessica.
Thanks so much, Tom. Elena, do you have any additional thoughts?
Yes, in our society, everybody is a family, included the person with the spina bifida, and some, everybody work together, share together, and listen together. And we also work accompanied by the RENAC, that it is a national network of congenital anomalies, and they help us a lot as scientific people, the same as some persons from Ministry of Health. Of course, we can do all work. I've shown you before about the campaign holders that help us when we need it.
Thank you, Elena. There's a question that came in for Scott, which I think dovetails nicely with what we've just been discussing. And Scott, perhaps you can talk a little bit more specifically around fortification initiatives. Who are some of the most important partners to connect with in a country when thinking about fortification?
Our mantra is public-private civic. So obviously the government is a key stakeholder, because we would request the government to actually make fortification compulsory. We've also found it very effective to engage disability groups. As I think everybody knows, the International Federation of Spina Bifida and Hydrocephalus is actually on our board, and we try and engage with those networks that Levin has globally for advocacy as we work in country. Of course, we work with the UN agencies, development agencies, and as importantly, and maybe more importantly, we engage the private sector very early in the discussions. At the end of the day, it's the millers that fortify. Governments don't fortify. I don't fortify. Development agencies don't fortify. The private sector has to fortify.
Thank you, Scott. I appreciate that. We have several other questions, but I want to remind our participants to please go ahead and submit any other questions that you may have or discussion points you'd like to raise in the chat box. We've had a number of questions come in about the effects of folic acid. Lynn, I'll put one to you first, and then I have a follow-on for Amy and for you to address as well. This question is something that you touched on in your presentation, Lynn, but the participant would like some additional information. Is it true that people who consume more folic acid in food are at risk for cancer and are affected more by cancer?
So the issue of excess or additional folic acid and cancer risk has been thoroughly addressed. In reality, if one looks very closely at the epidemiological data associating cancer risk with folate status, what one sees is that the lower the folate status, the higher the risk of cancer. So it's a folate deficiency in a cell actually makes that cell much more susceptible to carcinogenic factors in the diet. So the issue of the effect of fortification, again, has been documented in terms of its effect on cancer risk. And the one example I gave earlier is colorectal cancer. Those rates and other rates of cancer within the population of the US and Canada have gone down significantly since 1996, when folic acid was included in fortified staple products.
Thanks, Lynn. I appreciate your comments on that. And I'll also direct, when we send out and post the information from the webinar, we do have some scientific papers and documents that are available through the Folate Task Team website, which can provide further information and some of the resources that Lynn has mentioned in her talk and her answer here. Amy, we have a question over to you about the MTHFR mutation. And the question is, people with MTHFR mutation cannot metabolize folic acid properly, and this can potentially lead to harm to them. I guess it's more of a statement than a question, but I'd like for you, if you would just speak for a moment to that comment.
Sure, and thank you for the question. So MTHFR, or methyl tetrahydrofolate reductase, it's a mouthful. It's an enzyme that plays a role in how people process folate. And a common genetic variant of that MTHFR enzyme is known as the MTHFR TT or CT genotypes. And these determine how rapidly some people can process folate. And women that have the MTHFR TT or CT genotypes are going to process folate more slowly. However, they still can increase their blood folate concentrations enough to help prevent neural tube defects. And studies have shown that by consuming the recommended dose of the 400 micrograms per day of folic acid, that they still can get their blood folate concentrations to meet that, at a population level, to meet that optimal level as described by Lynn, and be able to be effective in preventing neural tube defects.
Thank you, Amy. Lynn, we have another question, which I think is best suited for you based on your background and some of the work that you've done. And it actually brings up a point that I'll tease out if you would speak to as well, and that is the difference between insufficiency and deficiency. The question is, can anyone speak to the interaction between folic acid and vitamin B12, insufficiency, deficiency, and potential risks of not providing B12 along with folic acid, and the benefits of providing both?
So the answer to the first part of that question relates to what's the difference in folate deficiency and folate insufficiency. So deficiency has been defined by the Institute of Medicine as a folate blood level that increases the risk of megablastic anemia. And so that really is the basis of the estimated average requirement on which the RDA is based. So if you will think back on that slide from the Irish study, for example, I think that's a very good example. When your blood levels are very, very low, which would be associated with an increased risk of anemia, NTD rates are quite high. But as you move further up and blood folate becomes normal, your risk of NTDs actually continues to decrease well above what would be defined as deficiency. So the term insufficiency is below that red cell folate concentration that's associated with an increased risk of NTDs. Above that concentration, there's no advantage of continuing to increase blood folate levels or intake.
Thank you, Lynn.
The second part of the question has to do with folic acid and vitamin B12. And so I will just deal with the population-based part of that first, and that is that, like folate status globally, we do not have a recent systematic review that provides us with solid evidence or documents B12 deficiency. And so that's a huge need to assess vitamin B12 deficiency globally. And as a member of the FDA Folic Acid Advisory Committee that advised folic acid fortification in the US and Canada, a primary focus of that committee is to ensure that adding folic acid to a staple food product will not lead to any negative consequences. For example, there's a lot of data that shows if you include folic acid in a bread product, for example, and you cook it, there's not going to be any adverse byproducts, breakdown of the folic acid. It's still available after that processing process. We do not have sufficient data as it relates to B12 to answer that. So that's certainly a defined research question. And obviously, because B12 is only consumed with an animal-based product, it is known and it has been documented in select low and middle income countries that B12 deficiency is a problem. And this definitely does need to be addressed. And we do know, to conclude my comment of feedback, is that B12 and vitamin B and folic acid are very much involved metabolically. And in some countries, Ireland, for example, a B12 deficiency has been documented to increase the risk for neural tube defects.
Thank you, Lynn. I really appreciate you giving that information and putting a complicated topic in clear, simple perspective. So thank you for your notes. The next question is really for our advocacy representatives, Tom and Elena, who are able to communicate at this point on Zoom. And it really speaks to something that you had mentioned, Elena, in your presentation about bringing the voice of the woman forward. But the comment is that moms don't take folic acid before conception because they don't plan their pregnancy. And we did hear from a number of you that, 50% or so on, a similar number of pregnancies are unplanned. So to you, Elena, first, and then Tom for additional comments. Can you speak to what you find to be one of the most or top ways that you engage with women to hear what they need or want from an information standpoint?
Okay, it is of course very difficult to reach everybody, and most of the women don't have planning about pregnancy. And what we do is in every province of our country, we have representations. Those women, those young ladies, everybody help to introduce how to prevent by means of folic acid. And of course, one of the things that we could have a great benefit was when all the flour was fortification too. And about the folic acid is going along the long cities, the very far short population, little populations, to invite people to know about prevention, to know about planning. And we do that with a magazine that it is the only written information given to everybody in hospitals. Sometimes the magazine is reached by young girls, and really sometimes women with a child with a spina bifida is receiving that, though it is very interesting for some different subjects, but perhaps it has arrived late to that family. Is it clear?
Yes, thank you, Elena. Tom, any further comments?
Yeah, I guess I'd repeat what I said earlier in terms of trying to be innovative and creative in the ways that we meet the wider audience. But also to, one thing that I often reflect on is that how at some point somebody was very effective in getting a message out there that you need to take folic acid when you become pregnant, because that everybody or lots of people seem to know, even though it's not actually correct information. So that gives me hope that it is possible to get a consistent message in there at some point if you work hard enough. But we still haven't got past that being the perception. One little thing that we did when we were in the UK, I don't know what it's like in other countries, but when you go to the pharmacist, typically they would put your medicines or whatever into a paper bag, and that's sealed with a sticker. And we managed to get a lot of pharmacies to put a sticker on that had the folic acid awareness message, or a lead away to the message on the bags. And it's just techniques like that, the kind of guerrilla marketing tactics to try and reach as many different people as possible in their everyday lives. But we can only do that as charities when the larger companies come on board to help fund that. So in the UK, it was Vitibiotics. And like I said, we're trying to work with a couple of companies here in Ireland to do the same, to get that message out there.
Thank you, Tom. I appreciate that. We have many more questions than we can address in the webinar today, but I do have one additional comment before turning the microphone over to Dr. Martinez for some final words before closing out. The comment is about the speaker from Uganda. Unfortunately, we're not able to have her communicate to you directly, but the comment is that she has worked within the Fortification network to monitor the fortification efforts in country, and that a Spina Bifida Association definitely has a role there. And the comment is, and the question is, Scott, perhaps you can comment on this, sort of that the role that the Spina Bifida Association has played with Fortification Network.
Sure. We actually we are piloting a new idea, when I would put it under advocacy. So I think, as many of you know, as we get fortification legislated and mandated, we rely on the governments to monitor that the fortification is actually happening as it is legislated to happen. And sometimes that works well, sometimes it doesn't work so well. Governments have competing priorities and there is a cost associated. So what we did in both Uganda and Malawi is we engaged in what we call the pull strategy. And what that strategy does, it engages the consumer associations and the disability groups to team with us. We did some training on the science and the advocacy, a lot of what was discussed today. And also we did what we call sentinel market monitoring, where these groups actually helped us collect samples across the countries by brand. And then we actually did both qualitative and quantitative testing to verify if those products were fortified. So the intention is to engage those groups, help in advocacy, challenge the private sector if they're not in compliance. Ultimately, we're not at that stage yet, but it could even become a media strategy so it's to supplement the government's monitoring programs and to ensure that if you have a law that says we're going to fortify wheat flour or maize or rice, it's actually being done properly.
Thank you.
Those groups have been wonderful to work with. It's incredible.
Thanks, Scott. I appreciate the comments and the comment from participants as well, to allow us to hear about that perspective and those efforts. We are at the close of the webinar. I want to thank everyone again for your participation, and we'll turn this over to Homero Martinez for final words. We will attempt to provide answers to the questions that have not been addressed, as well as a summary of those that have, with some of the follow-on materials. Over to you, Homero.
Thank you very much, Aliki. I am truly excited about the current webinar and extremely pleased to have had such a large attendance, greatly enriched by the questions and lively discussion. On behalf of the Folic Task Team, including its expert advisory group, as well as all interested stakeholders in local, regional, and global partners, I want to thank you, all our speakers, and to recognize all of you who have participated in today's activity. We are highly motivated to continue our work. with expectation that over the coming months, we will move closer towards implementing the roadmap outlined by the Folate consultation that was the basis for our current work. We have strong confidence on the solid foundation offered by the evidence presented here, and we have also great confidence that with increased awareness about the feasibility and identification of activities needed to reduce the burden of neural tube defects, as well as with a concerted efforts from different parties and stakeholders, we will soon see a change in the global panorama of neural tube defects. Each life saved and each disability prevented will mean a substantial change for each family involved. Further, the contribution that preventing neural tube defects to the reduction of infant and child mortality will bring us closer to reaching the SDGs. In short, the sum of these activities will mean a better world for society at large. In closing, I want to thank you all for your presence and hope to see you in the next webinar in March 2019 on laboratory capacity building. Stay tuned.
We are grateful for all of our speakers and the discussion that we had and the closing remarks that we just heard from Homero Martinez. Due to some technical difficulties, we were unable to hear from one presenter, so we offer this additional recording of Ruth Nalugya from Uganda. Over to you, Jess.
Thanks, Aliki. Ruth Nalugya is a social scientist at Medical Research Council, Uganda Virus Research Institute, London School of Hygiene and Tropical Medicine, and the president of the National Association of Spina, Bifida, and Hydrocephalus in Uganda. Thank you, Ruth.
Like Aliki has said, my name is Ruth Nalugya, the chair of the Spina, Bifida, and Hydrocephalus Association in Uganda. An association that has a membership of about 5,000 people, and these are caretakers of children with Spina, Bifida, and Hydrocephalus, together with those that are affected directly by the condition. Next. Yes, and I'm also a member of the National Working Group on Food Fortification, which was established in 2002 with multidisciplinary public and private sector agencies. Representatives are designed to provide leadership in steering the country's food fortification program. How did I get involved in the neural tube defect prevention? After giving birth to a child with Spina Bifida, I realized that the health workers did not talk to me about the importance of folic acid. And people in my condition, after taking a look at my daughter, they were wondering what I had given birth to because they did not have any knowledge about it. So I led a group that founded an association of Spina Bifida and Hydrocephalus. And it is through this organization that I joined other stakeholders in the awareness and prevention campaigns about the prevention of Spina Bifida. I also coordinated the consumer baseline market assessment survey on food fortification that was intended to improve compliance by industries to the national standards, because it was realized that according to the visits to the industries, it was found out that the industries were not fortifying because they say there was no demand for food fortification. So as parents, as an association of Spina Bifida and Hydrocephalus, we are spearheading this to demand for fortified foods. And currently I'm on the subcommittee reviewing and assembling a targeted advocacy package on food fortification. And this is being supported by Global Alliance on Improved Nutrition through the Enable project. Next. Yes, the magnitude of micronutrient deficiencies in Uganda is quite high, and this is commonly about vitamin A, iodine, iron, folic acid, and zinc, and it is really a public health problem with a prevalence of 31% according to UBOS and ICF International report of 2012. And despite of the numerous interventions, vitamin A deficiency has doubled from 19 to 38 in children and from 20 to 36 in women of reproductive age. That is according to the UDHS of 2006 to 2011. However, there has been an increase also in anemia in both women of reproductive age and children under 5 from 49% to 53% and 23 to 32% respectively, according to the UDHS report of 2011 and 2016. And according to the Rapid Assessment Survey on distribution of folic iron and folic acid through antenatal care centers, the demand and supply of IFA is still a problem. And another challenge that we are having is that the national statistics on neurotube defects in Uganda is still very limited. The pictures we see here, one of them shows a child with Spina Bifida that has not been attended to, and this child was about 7 months. And the first one is where we engaged the Minister of Primary Health Care during the World Spina Bifida Day 2018 in the awareness campaign that is national, at the national level. Next. In Uganda, due to the high magnitude of micronutrient deficiencies, we have put in interventions to address this problem, and this has been spearheaded by the Ministry of Health, and these are the key major interventions that we have, and one of them is the food fortification, where industries are supposed to fortify foods, and in Uganda, the mandatory food fortification for wheat and the policy on mandatory food fortification for wheat and maize is in place. Then we have supplementation, where all women who are pregnant are supposed to receive folic acid, and then improved crop productivity, dietary diversity, nutrition education or awareness, and crop biofortification. Crop biofortification, mainly in Uganda, we have yellow or orange sweet potato and rice. So all these are aimed at improving micronutrient status of the country or of Ugandans. Next. I've been engaged in different prevention activities in Uganda, and one of them is the supplementation. And in this, we've been doing the national and community awareness campaigns to improve knowledge consumption and promote periconceptional use of folic acid. When you look at the Ugandan population, there is very little that is known about preconceptional use of folic acid. And on the other hand, pregnant mothers have a negative attitude towards folic acid intake. Some of them say they smell badly, others they don't actually see the reason as to why they should take folic acid. Why? Because they've not been talked to about the very good importance of taking folic acid. And very few people still are aware that when you're planning for pregnancy, it is always good to take folic acid to prevent NTDs. According to the WHO guidelines of 2011, which is further in line with anemia policy and anemia strategy, which recommend intermittent IFA supplementation for adolescent girls and older women in situations where anemia levels are above. There is a policy now that is being drafted in Uganda to ensure that all girls of childbearing age start on folic acid. So the nutrition technical working group is still discussing that issue. But that dosage and distribution are the key things that have been tabled to be addressed before the policy is put in place. And fortunately, I'm on the committee that is discussing intermittent iron and folic acid for adolescents. And another activity that I've actively been engaged in is the industrial food fortification program. In Uganda in 1994, the universal salt iodization was introduced, and this resulted in 99% of the households consuming adequately iodized salt. And in 2000, maize flour and wheat flour plus edible oil was initiated. And today we have evolved from a voluntary program to a mandatory one. Like I said earlier, that in Uganda we have mandatory fortification of maize flour, wheat flour, and edible oil. In the year 2018, the Consumer Protection Association and the Spina, Bifida, and Hydrocephalus Association, we conducted a basic market assessment of fortified foods in Uganda, and this was considered a poor strategy as it relied on these groups to create a demand for fortification and compliance. But it was intended to complement the government's push strategy of making fortification mandatory. And on the market, before the team went out to the market, they were told, they started with a workshop to be trained about the importance of food fortification, and then they were taught about sampling, how to pick the samples from the market, and this is what they went out to do. But we purposed to pick out foods that had claims that they were fortified, and those foods had F logo. In Uganda, we use F logo to show that the foods were fortified. So during the analysis, we did a qualitative analysis and quantitative analysis. And at time, we found out that some of the products, some of the industries that had most of their products with F logo also had other products that were not fortified. And these products were either edible oil or wheat flour or maize flour. And remember, in Uganda, we have mandatory food fortification. So, and that though the results were not scientifically proven, but at least they were indicative. And we are hoping to do this program again to inform the industries and the policymakers on how best this can be done for them to enforce for the mandatory fortification. Next. During, as we try to do all these interventions, we have there are likely barriers in place to prevent us from achieving more. And one of them is the limited education and understanding of women and health workers about the importance of folic acid and intake. Then late presentation of women at antenatal care centers, because most of women in our country go for antenatal care past when they're about after the first trimester. So that late presentation of them is really still a problem. And lack of demand for fortified foods by the consumers due to lack of awareness among consumers on the rights and benefits of consuming fortified foods, and the negative perception of consumers about food fortificants. Most of them tend to say that food fortificants are there to cause cancer. Others say that food fortification makes maize flour dark or present with that dirty color, which they don't like, because most Ugandans want purely white maize flour, which is still also a problem. And there is also another challenge of smuggling of food products through porous border and poor enforcement at the importation sites of Uganda and industries. And lastly, there is high level of inconsistency among the producers, hence cheating the consumers. And next. Yes, thank you so much. The pictures you see there, one is fortified foods, the F logo that we use in Uganda, which shows added value, and foods that where we find folate and then folic acid tablets. Thank you so much.
Thank you so much, Ruth, for that really informative presentation. We're so glad that we got to hear from you today. We do, as with our other presenters, we did have a couple of questions that we wanted to ask you, and some of them came from participants, but these that we're asking you are based on your presentation, obviously, with us here today. So you presented some very nice information on the interventions and the prevention activities that are happening in Uganda, and your last slide really brought up some of the challenges that you continue to face. So these, the two questions I have really are around a couple of, one a general one and then one a specific one on the points on your challenges slide. Can you share with us, what do you think some of the better strategies are that you've employed, either prevention and intervention strategies that have the greatest impact or move the needle the furthest?
Thank you so much. I think from the Uganda's experience, we've realized that because since we have the policies in place, there is mandatory food fortification, for example, but we've realized that there is a lot of laxity among the industries. Like I said, that in 2018, a dialogue visit was made by the Nutrition Working Group on Food Fortification to industries engaged in food fortification, and they confirmed that one of the key causes of non-compliance, especially for maize industries, is the lack of demand for fortified maize flour by the consumers, which is mainly attributed to lack of awareness among consumers on the beliefs of consuming fortified foods. So for me, I would think that strict enforcement for goods imported and produced by local industries should be put in place by the government. Because as much as the demand might be there, but if the government strictly enforces mandatory food fortification and like they choose to close down the industries that are not fortifying foods, every Ugandan would be able, it will be automatic for all Ugandans to purchase foods from the market when they are fully fortified. And maybe another thing is for Consumers Association and Spina, Bifida and Hydrocephalus associations to team up and demand and advocate for the rights to fortify the foods. I think that is one of the key strategies that should be used. Strict enforcement of mandatory fortification of the policy on mandatory food fortification on all imported and produced goods, and then for consumers to team up and advocate for their rights to food fortification. Then the next strategy should be active engagement of Spina Bifida associations in the advocacy and awareness campaigns at both local and national level to influence policies and intervention programs like on iron and folic acid intake, especially to all the menstruating girls. I don't know whether I've answered you, but that is my thinking that those would be the best strategies.
Thank you, Ruth, for that. I appreciate hearing that, and I know our listeners will as well. Picking up on one of the threads of your answer too, our second question is around how consumers, how the people of Uganda do know and are able to tell whether the foods that they're purchasing are fortified. How can they tell now with what you have in place?
Yes, first of all, what we tell Ugandans is that not all foods on the market are fortifiable, but at least we have those foods that are declared mandatory to be fortified, and we always tell them that that is wheat, maize flour, and vegetable oil. And whenever they go to the market to purchase these products, they must look out for an F logo, because it is an indicator that whatever is in this packet is fortified. Then we also tell them to look out for other nutritional values or labels, nutritional labels, labels like for the health body. So we tell them to look out for things like calcium, vitamin A, vitamin C, and then iron. And during our campaigns, we always have technical people with us to tell us about how much, for example, intake, how much are you supposed to take per day, and how much quantity, for example, how much iron should be found in a certain food product. But one of the key things that we advise them to look out for is the F logo for the fortifiable foods.
Thank you, Ruth. I think that's great. I mean, I'm looking at it now on the screen, and it's visible, and it's a nice identifier, I think, to make it easier for the consumers. So that's terrific. Well, I want to thank you so much for your time and your and the information that you've provided. I know it will add value to the webinar, and we're so pleased to have your voice added to the voices that we're providing for others. So thank you so much. And we'll provide your details, contact details, in case any folks listening to the webinar recordings have questions that they want to follow up with you directly on.
All right.
Thank you
very much.